Good morning. My name is Alec O'Dare. I'm the Managing Director of Wound Care People. I'd like to welcome you to our first ever LinkedIn Live discussion. This is going to be a series of discussions with key people from within the healthcare industry, discussing various topics, clinical, service delivery, and much more. Today's topic is continence care, how the NHS can save millions, and it's a discussion between Dr. Orme and Alison Schofield. We'll be back with a series of these, so please do keep an eye on our LinkedIn pages. Let us know in the comments what you think, and please do enjoy the event. We look forward to welcoming you again soon.
Hello everyone, and welcome. Thank you for joining us today, and welcome to this first Wound Care People LinkedIn Live, and we are live from Sheffield. My name is Alison Schofield. I am Clinical Manager at Mole Digital and a tissue viability nurse, and I am delighted to have with me here today Dr Susan Orme, who is Associate Medical Director at Barnsley Hospital's NHS Foundation Trust. Welcome, Susie.
Thank you, Alison, and also welcome to all the people joining us today. Thank you for your interest.
So what we're going to be doing today, we're going to be talking about this new very important document, which Susie has been part of the steering group with this, and it's establishing consensus on the appropriate selection of continence pads to achieve optimal care while reducing the risk of harm, part of a holistic approach for people with incontinence. We're just going to watch a very short video and then we're going to start our discussion. So we've got lots to discuss here, Susie. It's a really important document that we have, and it resonates with me as a clinician, as a nurse, throughout every aspect of my career and in the varying roles and the patients I've cared for. And the aim of it is to reduce harm by addressing the fundamental aspects, the kind of soft aspects of care in some ways, quality of life, mental health and skin and well-being, which are affected by continence. Why did the steering group decide to put this together?
I think there's a recognition that there's been a disincentivising in continence care, particularly since its peak in 2000 with the National Service Framework for Older Adults. During COVID, it became more disincentivised. We spend a lot of money on continence care, a lot of money on containment, which is a direct cost, but also, particularly nurses are more aware of this in my profession, the indirect costs, skin care, mental health, quality of life issues. Yet we're in a situation where we spend a lot of money on containment, but there is very little patient choice. So we're spending a budget that isn't necessarily right for patients, isn't giving them the right advocacy, isn't giving them the right assessments, nor meeting their needs. There are very little randomised clinical trials on pad choice and containment projects and how that might affect the other domains, such as skin integrity and quality of life, falls risk, etc. So we got together with using the Delphi method to produce a consensus document so we could have a publication out there that would empower people and actually start discussion, because this is a powerful document to say this is what matters to patients. We also have to be cognizant of the fact that as the population ages, the health-seeking behaviour of the population changes. So the pre-NHS generation were very compliant with what doctor says, but the baby boomers are aware of what's available there. as somebody who's in their 50s, as we age, we are much more informed about healthcare. So patients will not accept the lack of choice they have in continence products at the moment. And we need to stimulate that discussion to make things go forward.
Yeah, absolutely. That's a really good point, that about the changing of the patient and how they're going to be, very autonomous in changing service provision. And we saw on the video there, 40 million people who will be affected by incontinence, experience continence issues just in the UK. And I know from practice it's not just continence service, which are largely unresourced, who are performing continence assessments and prescriptions for pads, but how accurate is that? And I've got a figure here of £80 million cost that the NHS has in provision of pad products alone. So what's the solution of that? What do we need to improve the resource for the specialism, service redesign? What do we do?
Well, that would be ideal. I think the specialism has been decommissioned over several years, but often now a continence assessment becomes a pad assessment, and that becomes what choice of no choice pad is that available to the patient, particularly the two products. I think the thing is we need to realise and recognise the indirect costs of continence as well. So it is a falls risk, it is associated with poor outcomes, it is associated with the considerable cost of pressure ulcer care, which is also very distressing and painful for the patient. And the whole point of this document is to get people to start asking the question. When we ask the question, the unmet need in the community will come out, and then it will also give us some more power to say this needs resourcing. Continence on its own is very badly asked about and very badly treated. How many times when we see an RCA in somebody with a pressure area or a fall have we actually addressed the issues and the continence issues behind that? It tends to be asked the question, but if it's an issue, it's just a yes or no. There's been no proper assessment of that patient, and particularly in pressure ulcer care, that's a vital part of it. And we are doing our patients a disservice if we don't ask the question. So the document is to say there is expert opinion on there, we can make a difference, it's important to patients, let's start asking the question in those indirect costs too.
You mentioned there about RCAs, and we've both been involved in investigations in our work in root cause analysis meetings, which are largely around pressure ulcers and falls for us. I've sat in on many of those as a TVN pressure ulcer nurse, used to be a falls nurse years ago, but that and often the risk factor that comes out there is, oh, well, there's continence related to it, but it's never given its own kind of, well, this is a direct cause. But how many people who fall and are admitted with a fractured neck of femur because they are getting up at night to go to the toilet? Even on acute wards, that's often the cause. So does it need to have its own kind of, harm label? Does it need to be a safety incident for patients?
Personally, I think so. But I think the issue with bladder and bowel management, and again with sexual health, is we feel uncomfortable asking the question. So it's much easier to say, this person's got a pressure sore without going into the reasons why. It's much easier to check somebody's footwear with a fall than ask them if they're getting up into the rush to the toilet at night. So we just have to start asking the question. And actually, as I said, I think the demographics of the NH population is they will ask the question for us. Yeah. So they will say, I've been falling at night, but I've now noticed I'm going to the toilet 3 or 4 times at night, and I'm rushing there. Do you think that might be related, doctor? So we are reaching a very internet-savvy, health-seeking questioning population who will make those answers for us. So we have to start the debate, and we have to start by asking the questions. And I think this paper, I'm biased, but this paper is written in a way that actually continence care isn't difficult. Asking the question is the most important part of it. Yeah. And most people will not be offended if you ask them the question. Often that's the in to tell them that these are the symptoms that are important to them. I think people still feel it's an inevitable part of ageing, which it isn't. It comes across all age. But we don't accept heart disease as an inevitable part of ageing, nor should we expect continence care.
It's not a sexy subject, is it?
No.
Yeah, and you know, if you sometimes see continence or, you know, skin conditions and all these things on a programme like Embarrassing Bodies, well, why should it be embarrassing? It needs to be in the mainstream, you know, just public awareness and media for us to talk about, doesn't it?
I mean, it's really encouraging. We were talking earlier about the effects of conversations on menopause. We need to have similar conversations on continence. If you look at the figures of how many people have occasional accidents as well as regular incontinence, you could be sitting in this room and we could identify 3 or 4 of us if that's the case. We need to be more open about it. I think it's not things that the medical profession are particularly interested in. So it's traditionally the burden's been on nurses. So we have to get the medical impression involved in this. It's very encouraging that the Royal College of Medicine now, as part of the geriatric curriculum, you can subspecialise in continence, and I think that's a very positive step forward.
That's really good, isn't it? That the education there in the medical side of healthcare is there, because then notice will be taken of it. And the study focus on, you know, the assessment and the provision of the right pad and product. Is this to be used in conjunction with toileting techniques as well?
Yeah, I don't think anybody would say that a continence assessment was a pad assessment. It's an adjunct to toileting, an adjunct to lifestyle changes, particularly reduction in caffeine intake, looking at constipation, looking at aids and adaptations. If the toilet is physically difficult for you to get to, then it might be commode or aids or adaptations. But equally, having a pad that doesn't fit the purpose of your individual patient is doing them a great disservice. It's the equivalent of putting the wrong size pot on somebody with a fracture, yet we do it all the time. The one size fits all model is a size that doesn't fit anybody, but we're still spending £80 million a year on things that probably aren't fit for purpose. It's not a great stretch to say, can we spend that money on something that is fit for purpose? And we use pads that actually help that patient maintain social continence while also trying to improve their continence goals.
Yeah, that is such a good analogy there, and it's, you know, that kind of investment in like preventative care or, you know, early interventions often is largely lacking, and we have largely throughout the NHS that provision of just 5 pads per day. And so often that assessment isn't individualised. You know, we've got that 80 million cost. Do you think because of those budgetary constraints, then it distracts them from the individualised care planning for this? And it's just like, oh, we can only have 5 pads a day. We're not allowed to have the pull-up pads and things like that.
And that's ridiculous, because often the patient is then spending that money themselves.
Yeah.
You know, the pull-up pads are more expensive, but are more expensive as a direct cost. The consequence of that patient falling because they've got a 2-part pad, because of the actual biomechanics of having something that doesn't fit you between your legs, so you're actually walking in a gait pattern that isn't normal, or if that patient then gets a pressure sore because that pad is poorly fitting and then leaks. So we have to take the pad budget away from just saying it's a pad budget. It's part of the holistic care of the patient, and actually one of the things this study does is recognise that continence has knock-on effects. We know this, but we have to acknowledge it, and we have to acknowledge that spending on continence saves money in other areas. You know, we all know the NHS is in difficulty, but spending 80 million on something that's not fit for purpose is not good spending.
Yeah. And, you know, you mentioned education provision into, you know, with some of the medical side of the programmes. But what about in, like, social care, which in social care, carers are largely at the front line of this care provision in residential care homes, or home carers are going to people's own homes. You know, do we need to educate better there? And will the document, you know, form this provision for that?
I think the document recognises that patients with continence issues have domains in depression, anxiety, falls risk. It's been known since the 80s that carers in care homes perceive people who are incontinent in a more negative way than people who are continent. So there's been a known for an educational need from the 1980s that those patients actually do require toiling, and they're not doing it on purpose, they're not attention seeking. I think there's a lot of investment in education needs to go in care homes, because the most vulnerable patients in our population are looked after within residential settings.
Yeah. We've got lots of questions coming in from the audience, so thanks for people for that. People want, obviously, really resonate with this and want to get involved. So I'm just going to look at some of them what's come in, and there's somebody here asking that we've dived right into talking about the study details, but could you, Susie, tell us sort of the crux of what the study was about, the kind of those like 7 elements and things?
Yeah, because there's a lack of trial evidence and meta-analysis with PAD provision. It was a group of experts who rated various domains and what was important to the patient, so skin integrity, mental health, quality of life, falls risk. And then we came into a decision on what consensus would be. Consensus would be greater than 60% of respondents agreed, high consensus greater than 90%. Then that questionnaire was taken out to interested healthcare professionals in 2 rounds, and then we noted consensus from that, and then what was important statements and important going forward. The Delphi method allows us to do this. It's a nice approve it, but it's actually recognising the interested professionals, what they think is important and what is important to care going forward. So it is a valid research method for finding out what we need in terms of continence provision and what we need in terms of PAD provision for patients.
And so how would you recommend for people out here watching, not just clinicians, but service leads in trusts, integrated care systems, the NHS, to make sure this is implemented into practice and the recommendations?
I think the first thing is to read it, is to get the departments that are involved in continence care, so tissue viability, infection control, geriatrics, fall, orthopaedics with fractured neck and femurs, to be aware of the importance of continence management, and also actually involve some patient advocacy groups. Most hospitals have impact into Parkinson's disease services, stroke services. Actually get some patient advocacy on this, and actually ask patients what they want, and then look at some studies around what your indirect costs might be within your service, be that primary care or secondary care or community hospital care, and actually how we can make that better for the patients, save money and also be more effective in what we do. So the idea is it's a springboard for ideas. We are, any of the group, and as lead author, me particularly, is available to support and advise ways that you may go forward with this. We already have had interest from 2 trusts who've looked at this and said, how would we build on this going forward? And certainly we are available for advice on that. We want to get the message out. So it's not difficult, it's an easy thing to treat continence, it matters to patients. I would argue that if it was yourself, it also matters to you. So we need to think as clinicians what matters to us on a day-to-day basis, not necessarily the things that we measure in terms of quality of care. So it's a springboard to actually start asking the questions and realising that you can make a difference as a clinician. Yeah,
and the NHS long-term plan, it talks about tackling health inequalities, giving patients that autonomy back for their own care, and we talk about self-care, supported self-care, but patient-centred care, and within this, and everything you've just said there, we don't always do it that well. We use the terminology, don't we? But, we could really make a difference by that real involvement, and we just need to ask patients, as you said.
Absolutely need to ask the question, and what's important to that patient on a daily basis. If we put ourselves in the position of the patients, we do not wake up and think what our serum cholesterol is. We would be bothered if the choice of pad or our continence status meant that we couldn't go out to the shops that day, or we couldn't wear the clothes that we want. So actually patient-centred goals is individual-centred goals on what we'd want for ourselves.
Yeah, and there's not just the patients themselves, but carers and people who are informal carers in households, and a lot of patients have dementia and people making care decisions for them, so that's great. We've got another question here from somebody saying that their patient's assessment indicates the need for more ergonomic pads. How do I rationalise to commissioners that it will cost more?
It costs more in terms of direct costs, but then if you look at how much you're spending within that subgroup of populations, how many times has that patient been admitted, what is their care burden, ask the relatives, ask if they're actually buying pads themselves, ask if that patient's ever had any pressure ulcers or urinary tract infections that required admission. It's actually teaching the commissioners about the indirect costs, and I think mostly the commissioners aren't aware It's isolated. So if you use some individual patient stories about the difference it would have made to the patient journey of that individual, we only have to stop one fractured neck of femur to make any amount of patient choice for pads worthwhile.
Yeah, and the patient stories, and I know because I've done this myself, are very, very powerful for taking to trust boards, etc. And you know, but those indirect costs of, you know, pressure ulceration, what is it, you know, 2 billion annually, and
Absolutely.
the cost of falls, UTIs.
A great deal of pain to the individuals as well.
Yeah.
But as I said at the start of this talk, the commissioners will have to listen to the fact that the population is changing. So there will be pressure from external patient ages and individual patients to change the way we deliver continence care, because they will research this themselves and they will put pressure on services to give them the services they deserve.
Yeah. It's a revolution.
Absolutely.
Right, we've got more questions coming in. So somebody's asking, to what extent is the Delphi consensus method recognised by NICE, National Institute of Clinical Excellence?
Well, it's one of the recommended tools for when there is not meta-analysis and when there's not case studies or randomised clinical trials. So NICE recommend this as a way to actually do meaningful research by expert consensus and devolving those questions to other interested professionals. So in the absence of a randomised clinical trial, which would be very difficult to do with pad products, particularly in a vulnerable population, it is a powerful tool in order to actually reach consensus on what good care is. So, you know, NICE recognise it, and it also makes it a valid research document.
So glad you mentioned that, about because, you know, to get, like you said, randomised controlled trials, you know, which often we see at the top of the evidence tree, it's very difficult in subjects like this, you know, and this is, you know, it's qualitative factors, isn't it? But we have to listen to that. It's not always about data and numbers. It is about what's affecting the individual, and this is what for me makes this very powerful.
Well, there are lots of studies, particularly on continence-related drugs, antimuscarinics, around reduction in an increase in voided volume. That's not the sort of outcome that a patient wants. You know, a patient wants social goals. So social goals around soft qualitative targets, like being able to go to bingo or being able to stay at home. And more importantly as well, reduction in carer burden. You know, we have an increasingly elder population being looked after by partners and children who are also getting into the middle age and older age as well. So carer burden is a really important thing. And in the individual costs of what it then costs to go into 24-hour care, it's still a major factor, continence care and continence provision, in the decision to go into institutional care. So all these things are attained to in the document, and they're a sort of a powerful tool to get people to listen. And it is a valid research methodology. So it isn't just a group of experts giving opinion. The Delphi consensus and the rounds of the Delphi consensus actually give it more power as a document and as a research tool.
Yeah, brilliant. Right, they're flying in thick and fast now, Susie. So
I'm just going to have a sip of water.
Yeah, no, go for it. What are your thoughts on the gender-specific care in relation to males that was discussed in the study?
Yeah, it's very interesting because women have a specialty of their own. It's called obstetrics and gynecology. You know, men, within urology, there's also cancer care. There's very few specialist continence urologists who only do men. They'll tend to do men and women. Men and women, as I don't need to tell anybody in the audience, are designed very differently. Where they urinate, if they're incontinence, is also different as well. And actually the way they wear clothing or the way their clothing holds. So, you know, the two-part pad system is mainly designed for women and not designed for men, and where men would actually have urinary leakage. So, and also men are very reluctant to come forward. They're much less likely to come forward with their continence issues than women, and suffer more burden as an outcome, really. So I think we have to recognise that we are not anatomically aliens who never have genitals, and that the genitals of men and women are fundamentally different. Therefore, where they leak urine is fundamentally different. So if you look at a standard two-part pad, how does that fit the different needs of men and women?
Yeah, and then, you know, if people are not accessing services, and because, you know, they might say they're feeling shame, embarrassment, then, you know, that has a knock-on effect for mental health. Should we be doing mental health assessments alongside continence
Absolutely.
assessments?
There's lots of evidence that incontinence reduces the social outcomes and the social interactions you have. It is associated with embarrassment and shame. Part of that is the fault of the professions who don't actually ask the questions openly. We have to ask the questions about continence and fecal health and sexual health without embarrassment ourselves, that's a normal part of the question and we should ask people like we do about pain. So if somebody comes forward and the treatment that we give them is not a proper continence assessment but a pad assessment, the pad isn't fit for purpose, it doesn't fit in with their clothing and how they want to run their life, it doesn't make them feel better, it potentially makes them sore because it doesn't fit them, then that's going to disincentivize people to talk about, actually, it's going to stop the patient power of saying, I went to the doctor, they did this, I feel much better, you should do that too. It's actually going to make the burden of continence care go deeper underground.
Yeah, absolutely. And then there's the, the pressure, also the falls aspect. And, I say I used to be a falls nurse years ago with the National Service Framework and was going out and doing those assessments. And I'm trying to think, did I include continence as part of that falls assessment? I don't know if I did, but it was such an important part. So we should integrate that surely as well.
I think and I've been talking about this as an interested continence geriatrician for years. Any falls assessment should include a continence assessment. Any stroke assessment should include a continence assessment. Any Parkinson's clinic should include a continence assessment, as in any of the chronic neurological conditions like MS. I just don't think we ask the question enough. Yeah. I think maybe because we aren't educated enough as healthcare professionals on what we can do because of the lack of randomised clinical trials. But this is a starting point. Ask the question and you will get results. You'll also get patients who are better cared for in a more individual approach, and also patients who will then have the power to tell other individuals that they don't have to cope with this. It is an inevitable part of life, and it isn't something they should have to put up with either, because we can make it better.
Can't brush it under the carpet anymore.
Absolutely
can we? No. And if people want to take it forward to commissioners, but obviously commissioners, I know it's the ICSs are coming in, but the people who are holding the purse strings, what's that? How do they do that?
Again, I think it's about managing the indirect costs. We all have targets on pressure ulcers. We have targets on falls. They're massive targets that we have in hospital that we have to reach. Why not say we can actually improve the targets on those things that we're measured on by the CQC and externally by actually doing a very important part of the assessment? I think most commissioners aren't aware of the links. Many commissioners are not clinicians. Get them to read the paper, get them, educate them and tell them actually how it might make a difference to targets that are important to them. We're not asking to spend more money, we're asking money to be spent more efficiently and more patient-centred. And you can reference from that a reduction in your falls risk and pressure areas risk, and then actually put that as part of put your costing argument as part of the effect on indirect cost too.
Yeah, it's all part of the same circle, isn't it? So
absolutely. We can't take pad budgets in isolation from the rest of the patient. And falls and pressure areas is a massive target, particularly for secondary care.
Yeah, no, that's really good advice for people to take forward there. So I think we've probably got time for another couple of questions. So how can the findings of the study be implemented into educational programs? I know we identified that they need to be. What do people need to do? Again, read the document. But then
read the document and actually become an interested person yourself and ask the questions. All the people who are involved in the study are available to give help and advice and will provide educational materials. There is also a wealth of educational material on the International Continence site and the Bladder and Bowel Forum as well. So there are methods in order to do this, but one of the most powerful things you can do is have a patient who's had good continence care, give a patient story. That is one of the most powerful education tools we can do. But start to ask the question and realise it isn't a difficult subject to tackle. I think one of the reasons, particularly the medical professions don't do it, is because we're not taught about it at medical school. So therefore, if we don't know about it, we perceive it as difficult. But start on the ground floor and then raise the message about how important it is. But patient journeys are important, and there is a wealth of resource out there to aid you with it.
Yeah, I absolutely agree with you there. Couldn't agree more. And so we've got one last question. Gosh, this time we need hours to talk about all these issues.
I could talk about it for hours.
I know, me too. So if you are a clinician and you want to take the study findings forward, we think we've mentioned that actually last question. That was the last question. What do we need to do? So the impact on healthcare professionals in this current current climate, we've identified, you know, you know, there's lots of issues happening. So, you know, we've Dr. Susie has kindly, you know, told us how to take this forward. So you know, we need to then, you know, do take it back into practice and listen, but read the document first. So I think that kind of wraps up our conversation. So I want to thank you so much for being with us here today in Sheffield, and thank you so much to our audience for listening. The first ever Wound Care People LinkedIn Live. Thank you so much to Essity for sponsoring this event too, and we hope to see you again at some point in the very near future. Have a great day.
Thank you for your time.